Hi, I'm Jay Kim, and welcome to the Smart Soul Hub podcast. I am a senior podiatrist in Queensland with a background in neuroscience research, and this podcast is where we bridge the gap between primary research literature and what actually happens in the clinic. This is part one of a brand new series diving deep into the evidence behind perineural injection therapy, or PIT. To kick things off, I want to be upfront about why I even started looking into this. About a year ago, I completed training in prolotherapy and PIT, specifically the Liftock method. The reason I sought out the training was simple. I had too many chronic musculoskeletal cases that I was struggling to help. Plantar fasciitis is a good example. As podiatrists, we are supposed to be the experts in this condition. But if I'm being brutally honest, for truly chronic presentations, my success rate with standard conservative care was sitting at less than 40%. The peer-reviewed evidence I reviewed describes outcomes broadly consistent with what I have observed clinically, though individual responses vary considerably. My explanation to patients has been fairly basic. I tell them that this low concentration 5% dextrose solution acts as an anti-inflammatory, reducing irritation of the local peripheral nerve. But it started to bug me. It's an oversimplification. I wanted to understand the mechanism properly, so I decided to go back to the literature and look at the highest level of evidence available. The very first paper we are looking at is a 2025 systematic review and meta-analysis by Azizi and colleagues published in the open access journal Helion. A systematic review sits right at the top of the evidence hierarchy. The authors searched 4 major databases and pooled data from 13 studies involving 754 patients. Most of these were randomized controlled trials looking at upper limb compression neuropathies, specifically carpal tunnel syndrome and ulnar neuropathy at the elbow. They compared 5% dextrose water, which we call D5W, against treatments like corticosteroids, normal saline, platelet-rich plasma, and hyaluronic acid. Let's look at the headline finding first. Pain relief in the short term, meaning up to 4 weeks. D5W performed similarly to corticosteroids. There was no significant difference in pain reduction, but when compared to normal saline, D5W was significantly superior with a mean difference of minus 1.30 on the visual analog scale. That is a crucial detail. If injecting fluid was only working because the sheer volume of liquid was physically pushing tissue away from the nerve, a process called hydrodissection, then normal saline should have performed just as well. The fact that dextrose beats saline tells us it is doing something biologically active. Then we look at the midterm data from 1 to 6 months. This is where the picture becomes really interesting. D5W significantly outperformed corticosteroids in midterm pain relief. This makes biological sense. Corticosteroids work aggressively early on, but their effect tends to wane. Dextrose, on the other hand, appears to have a slower onset with a much more durable benefit. Functionally, patients receiving dextrose also showed statistically significant improvements on the Boston Carpal Tunnel Questionnaire at both short and midterm time points. However, there were no significant differences between D5W and control groups when looking at nerve conduction studies or nerve cross-sectional area on ultrasound. If you're a clinician, you might immediately see that as a red flag, but it's actually not surprising. Neurophysiological normalization is an incredibly slow process. It can sometimes take 12 months or more, and some patients never fully return to their baseline electrical values even after complete clinical recovery. As the authors cite from expert opinion, nerve conduction studies are better used to track recurrence than to measure short-term treatment response. So, what is the dextrose actually doing? The review categorizes the effects into two broad buckets, mechanical and biological. The mechanical effect is hydrodissection. Ultrasound-guided injection physically separates the nerve from surrounding compressed or adherent tissue, reducing pressure and improving local microcirculation. But the biological effects are where this gets fascinating. The review outlines three main pathways supported by laboratory data. Mechanism 1 is the suppression of neuroinflammation. Specific glucose concentrations effectively inhibit TNF-alpha-induced NF-kappa B activation. Essentially, dextrose interferes with the inflammatory signaling cascade inside the cell at a molecular level, turning off the production of pro-inflammatory cytokines. Mechanism 2 is the reduction of neurogenic inflammation. This is based on Liftocht's foundational work proposing that dextrose inhibits capsaicin-sensitive receptors known as TRPV1. Blocking this receptor suppresses the release of substance P and calcitonin gene-related peptide. Both of those are major drivers of pain and swelling in and around peripheral nerves. Mechanism 3 is the one that genuinely surprised me. Nerve regeneration via Schwann cell activation. Studies have found that elevated glucose levels stimulate Schwann cells to upregulate key neurotrophic factors, specifically nerve growth factor and brain-derived neurotrophic factor via a pathway called P42-P44-MAPK. It is important to note that this finding comes from preclinical laboratory and cell studies and has not yet been definitively proven in human clinical trials. With that caveat clearly in mind, this suggests that dextrose isn't just anti-inflammatory, it may actually have a neuroregenerative effect. It perfectly explains why the clinical benefits of D5W appear to outlast what you would expect from a purely anti-inflammatory drug. Now let's ground this and talk about where this sits in the evidence hierarchy. Yes, this is a level 1 systematic review, but we have to be honest about the limitations. The biological pathways mentioned are largely drawn from level 5 in vitro cellular evidence and prospective papers. The TRPV1 inhibition pathway in particular is considered theoretical and speculative. Also, nearly all of the 13 studies in this review used ultrasound-guided injections to deliver larger volumes directly at the entrapment site. They were deliberately trying to achieve that mechanical hydrodissection, and that brings me to a significant clinical consideration. The PIT technique I use in clinic is subcutaneous. We target Valix points along the nerve course, often starting far away from the primary pain site. We are not doing high-volume hydrodissection, so the mechanical component that likely contributes to the outcomes in this meta-analysis doesn't apply to my approach in the same way. But what absolutely does apply are the biological pathways. The fact that injecting subcutaneously along the nerve course still produces clinical improvements strongly suggests you don't need to be directly at the entrapment site to influence the nerve's metabolic and inflammatory state. The question is, how exactly does a subcutaneous injection trigger these cellular pathways? The mechanism deserves a much deeper look than a high-level summary can provide. To sum it up, current evidence suggests 5% dextrose is a promising and well-tolerated option for managing nerve pain, with mid-term outcomes comparing favorably to corticosteroids in the studies reviewed. While it matches steroids early on, it pulls ahead in the 1 to 6 month window and is doing so through a combination of mechanical spacemaking and complex biological signaling. If you want to read the full breakdown, you can find the article, my clinical notes, and all the references over at smartcellhub.com. Thanks for listening. Next time in part 2, we are going to dig directly into the cellular evidence. I'll see you then.